Hey, thanks for having me. I'd like to thank the Better Medicare Alliance for having BlueGenes today. My name's Nick. I'm the CEO over here at BlueGenes, and not like the ones you wear, even though I didn't wear BlueGenes today, but like your genetics. And yes, it's a pharmacogenetic platform. I know we all have heard about pharmacogenetics, and you're like, oh, God, diagnostics. But we are a lab. We do perform our own testing in-house. I like to tell people we're really good at it, but I own the company, so I would tell you that no matter what. But in truth, the test portion of this process is a complete commodity business. There's only 3 or 4 equipment manufacturers in the world that make this type of equipment, and there's only so many genes that have genetic clinical validity to them. So there's no novelty in having a test. If our competitors tell you that their test is special, I'm sorry, their baby's not special. The problem with pharmacogenetics and the reason it's largely failed in the market isn't having access to test results. It's that it doesn't fit into the clinical workflows for the providers, and the information tends to become obsolete over time. It's a once-in-a-lifetime test. There's no doctor in America, I'm sorry, I don't really care what anyone says, that's looking at 10-year-old pharmacogenetic tests to make clinical decisions. They disappear at some point. New providers either don't know that the test exists because they didn't order it, or they're too lazy to look for it. But if no one looks at this information, and I'm a huge believer in precision medicine, it's not worth your plan's investment at the end of the day. So we have to establish that we're going to improve care, or improve outcomes, and reduce the cost of care. And so we at BlueGenes, did 3 insurance actuarial studies, one on opiates, one on SSRIs, and one on Plavix as an individual drug. And just to be brief, I'll talk about Plavix for a second. In this instance, we took publicly available Medicare data, seems apropos, and we extrapolated against all categories of care. And we were able to show a $4,499 per member per year savings. And that's just on Plavix, not the US Pharmacopoeia. The interesting notation is that none of that savings comes from pharmacy cost reduction. Plavix is a cheap generic drug. You're going to replace it with something. Maybe the new drug is even more costly. So the savings are an adverse drug reaction utilization. We heard Dr. Oz talk about medical error. I think it's the 4th leading cause of death now. So about 28% of the population is considered an ultra-rapid metabolizer. Plavix just means you can't take it, goes right through your system. There's no therapeutic benefit to it. If you do as an ultra-rapid, you're 8.5 times more likely to have a bleed event. If you are a poor metabolizer of Plavix and you are stented, one of the most popular post-stint drugs in America currently, your most likely outcome is a re-stint. Now, other drug categories like SSRIs, opiates, oncology medication, you're going to see significant savings in the pharmacy cost reduction category. So here's where we're different. There is no one else in the world that can do what we can do. We're patent pending. We plug into the PBM. We are an open source API. Theoretically, you could stick us anywhere, but most of the PBMs put us into their adjudication engines. So how it works is a patient goes to see a doctor. A doctor prescribes medication out of their EMRs. It goes from the EMR to a switch to the PBM for insurance verification. When it gets to the PBM is able to recognize the member as a BlueGenes customer by a patient identifier code, an organization code, and then other authenticating factors, name, birth date, et cetera, and it's able to send us the claim in real time. So in less than 1/2 of 1 second, our system can process the claim and query it against a stored patient test profile. That means the patient would have already tested and been on our system. We send a very simplistic response back to the PBM. We don't want to confuse them. It's either a 0 or a 1. We call it red light, green light. If it is a red light, and that's what your plan wants us to do, we will deny that claim. The messaging is customizable and tailored to receiving audiences, but essentially it is a claim denial. And to doctor, we give them all the replacement drug options, but we work for the plan, so we filter those drug options. We filter them by formulary. We could filter them by drug tier. We could filter them by drug cost. You give us the data. At the end of the day, we work for you. So the reason why we're having a lot of success in the market, we don't require a behavioral change. Your Medicare patient doesn't have to remember that they ever took this genetic test into the provider. We feel like a coverage determination or prior authorization denial. They don't love those, but they're used to dealing with them. And then, just to get granular on it, you can't test everyone in a population. There's no return on investment for the plans. So we stratify those populations into high, medium, low risk groups, and we focus on those members that specifically should be tested. There's been a lot of discussion today on AI. We partnered up with Google, and I think that Google may even say that we have the most sophisticated AI within the small sphere of PGX. But we are able to work to educate providers so we aren't seen as adversarial to provider for denying claims. We work with the providers to educate them to understand why the patients are unable to respond to these medications so we can improve outcome and hopefully save some money at the end of the day. I will be around to talk. I mean, I've got a couple minutes left. If anyone has some questions, great. If not, we really appreciate the opportunity to be here in Washington. Came all the way from Scottsdale, Arizona. So, all right. Thanks.